What value does a health insurance company add in 2026? Are health plans useful at all in the health supply chain?
First of all, I think health plans absolutely positively have a role in the economy. There is a value-added role for health plans. The capital markets right now have a lot of question marks over the historical values of large insurance companies. There was some clear sentiment in the investment circles. Is this an uninvestable sector?
Meet Chris Dallas-Feeney, Executive Advisor at ZS Associates. Chris explores why value-based care is struggling and what the future holds for the viability of health insurance plans.
One of the things I've heard very loudly and clearly is docs and hospital systems need to kind of team up in any given market to create greater bargaining power. How can we show up as partners in negotiations with major insurance companies to say, hey, brother, you want to do business in this marketplace, you need to deal with us as a unified force.
What is the purpose of value-based care? Are insurance entities just trying to dump risk on the hospital systems? Where have we lost the way on value-based care?
Okay, lots to unpack.
Welcome to our podcast. I'm inviting my friend Chris Dallas-Feeney. I'm your host, Omar Haq. We're going to talk about the challenges that we're faced here with healthcare. And welcome to the podcast, Chris.
You bet.
Please introduce yourself. Tell the audience why you're so damn awesome. We've known each other for 10 years. It's been 10 years. I can't believe it, I'm very excited to have you here. We're launching something new. It's exciting. And I just, I really want to invite people that I really care about. I enjoy their company on a personal and professional level. So please introduce yourself to the audience and tell us, I know for a fact that you were the SVP extraordinaire at our previous employer, leading strategy for the company, partner at KPMG and Booz Allen and PhD and political science and all kinds of stuff. So please tell everybody about yourself.
Well, first of all, thanks, buddy. It's really good to be with you. It's a great honor. It's a great honor to have met you, and I'm better for it. So you're a great friend. So Chris Dallas-Feeney, and I'll start with way back when. I started my career in public accounting. I did the CPA thing, worked with a firm called Arthur Young, which is no longer in existence, went into Ernst & Young. Then went into KPMG and transitioned into the consulting world at that time, mostly financial management, which was a natural progression for me from sort of the audit world. I loved the audit as a profession, but I knew it just wasn't something I was going to stay in, right? But I transitioned into the consulting world at what was then known as Peat Marwick Mitchell, now KPMG, following a series of mergers, and went on to become a partner there. Loved it. It was heavy tech. And not as we understand Silicon Valley tech. It was mostly the era of large enterprise resource planning systems, but these were huge investments in tech that were strategic bets for most of the companies that were doing it. So an ExxonMobil or governmental entities like PennDOT in the state of Pennsylvania, they were making massive bets on technology to mostly handle a lot of transaction processing stuff at the time. And like that, but it never really felt like it was scratching the itch in me around, hold it. There's this thing called corporate strategy where you could at some point make company bets on things, whether it was markets to go into, markets to leave, businesses to acquire, businesses to shed. So I was really intrigued by the more big bet strategic sort of questions that companies were making. And I wanted to learn how to do that, learn that craft. And I knew I didn't know how to do it. I had certain skills, but it wasn't kind of operating at that level of analytics, because quite honestly, when you get up into the strat space, there's a lot less known. There's a lot more unknown. And so you're kind of making hypotheses about what you think will work, probing a little bit, and then seeing whether, I have a reason to believe. But it's usually with quite a bit of risk and sometimes uncertainty, and there's a difference, and we'll come back to that later. So I made the move to Booz Allen in Hamilton up in New York and focused mainly at the time in a couple of, it was more around the strategy function across a couple of different industries. Financial services was a huge part of my practice, and then progressively migrated to some of the pharmaceutical space. And then following that, I said, I'm getting close to the point where if I don't do one of the things I set out in life to do, which was to pursue my PhD, in at the time I thought was military history, I better get on with it. So I ultimately exited the industry for a bit to go out and do my doctorate at George Washington. I had done a master's at Georgetown just to see whether I could carry the weight, right? I'd been out of school for quite some time. And that went pretty well, loved it. Went to do the doctorate at GW, and it was daunting because in the first 2.5 years, you got to read like, I don't know, 500 to 1,000 pages a week. And, I was reading cartoons. It wasn't like I was consuming complex literature. So the kids were like, zipping by me, and I'm like, oh, gotta get this together. So they came together. And then as you get to the point where you're about 2.5 years in, you start, okay, you got to do comprehensives, you got to do the orals and so forth. You get to the point where they say, okay, you're not dumb. You can go on and do your dissertation. Then it takes another 9 months to run that gauntlet because usually you start out with a project that's going to take 15 years. And your committee says, no, not doing that. So so my committee had mercy on me and helped me figure out something I could do in 3 years. And that was a fantastic sort of time. And then I went into teach and also return to the consulting world part-time in a firm that I'd started. And it was a nice mix. I enjoyed teaching. I enjoyed my consulting practice, but I felt like I wanted to do a few more things in the consulting or in the business world. So
That's where we met.
that's right.
But this is where I have been always needing to ask you, we just never got time to sit down and talk about it. How did you go from management consulting, strategy consulting, to military history and political science? Like what, this seems like it's totally out of left field.
It simmered since I was probably a preteen. I'd always had interest in military history. And remember, I'm born in the mid 50s. So my youth and I'm one of eight. I was the seventh of eight kids. So my, I had a lot of influence about sort of World War II, uncles, parents, etc. And so it was something I grew up with. And it was like, my God, the world was on fire. It was, by some accounts, 50 million people perished in that war. It was like, and the heat. So so it was something that was always interesting to me. So I always thought that I would do advanced degrees in military history. It's funny, when I was leaving college and I was going to college, I said to my dad, I said, Dad, I want to study the German language and military history. He says, how about accounting? I'll underwrite accounting, but I'm not. And so I dragged German and military history for the first 2 years, but ultimately I said, okay, I got to make a decision.
I had a very similar conversation with my dad. I said, Dad, I want to be an actor. He goes, how about you be an actuary instead?
Yeah, it says, "You get a job." There was various ways that I love my father. I love him. He's a very, very loving man, but it was a very practical man. He was born in the early 20th century, so he's like, "Look, dude, I went through a depression, and you need to make sure you have a skill that you get paid for." So I knew I was never going to be, oh God, I so want to be, an auditor. I really wanted to be a researcher in military history, political science. In fact, the choice I had to make, and I know we'll get to healthcare in a minute, the choice I had to make was military history. The history degrees were different research programs than political science. Political science forced you to create theoretical apparatus, a logic, something that was testable empirically, and I liked that. History was different. It was important. Political scientists need historians and need journalists, but we like to then say, why did that happen? And have an empirical mechanism to test it. That was probably one of the most attractive features of the political science aspect to it. And so I could study, my focus was on resilience of these violent non-state actors, and I wanted to understand what explained that. And in particular, was it something other than muscle? Were there things about social factors like legitimacy and so on, which was kind of a slippery variable to track. Anyway, it was, for me, it was a natural transition. But when I came back to industry, I just felt so much better prepared, Omar, for sort of the vagaries, the complexities of bigger bet strategic questions, and I was attracted to that. And I knew my limitations. I knew my limitations weren't, I wasn't going to be a chief operating officer. I was going to be chief strategy officer. I was going to lead sort of the questions around innovation. They tended to have longer time horizons. And so I enjoyed the more complex problem to unpack. Not that the operations challenges weren't interesting and important. I just knew I wasn't all that. That wasn't where I could, bring my value. But I loved being back in the industry, and now working with ZS Associates, working with Accenture in different industries. ZS is with health plans, and that's kind of been a big chunk of my time. Accenture in the pharmaceutical space. And it's just been, at this point in my career to feel that you can still help
Right.
and still, and it isn't just necessarily in the crack in the case as much as it may be even trying to upskill and build and encourage some of the guys that are 30 years younger in their career.
Well, CDF, that is fantastic. I really appreciate, you sharing all your experiences. And I will tell you this, I'm not 30 years younger than you, but you are a big motivator for me. I mean, I've been doing this, launched this consulting practice because I said to myself, if CDF is still going so damn strong, I sure as I'm not going to sit back and retire, you know. And it's just such a huge motivator for me to have you in my life so that, I just, every time I talk to you, I'm better for it. I
You
learn
are
so much.
smart and young.
Yeah.
And so, it's 48 years now, Omar, I've
Yeah.
been out. And it
And you're still going strong,
but
man. I don't see you
but
backing down.
I feel like, hey, this is cool.
And then that's the thing that is just I find it so amazing and so brilliant and so energizing. I know guys 20 years younger than you that are just packing it in already.
Yeah.
And just it's unfortunate that all that skill set out there, and we're starting to lose it. And that now let's bring that back to our question that you and I have talked about, and that I've been in the healthcare industry, health plans specifically, for 30 odd years. You've been doing this in and out for almost 50 years. And you and I have had some pretty robust discussions around it. I'd love to hear your perspective on, I hear this from other executives as well, that question, are health plans, well, one of the things is, are they a viable investment? Another way to put it is, are health plans useful at all in the health supply chain? So what value does a health insurance company add in 2026? We know what it added back in the 80s
Yeah.
when managed care, when you use the terms managed care, define managing care, managing people's lives, making them better, you know, while being cost effective. Somewhere along the line, somewhere in the last 30, 40 years, it feels like the insurance industry's completely lost track of what its main purpose was. And now, as an outsider, you talk to people and they're like, well, what does my insurance company actually just do? I talk to my clinician, I talk to my pharmacist, and all I get from the insurance entity is, you can't do this or you can't do that. Or, my wife asked the same question. She goes, they know I need a CT scan or an MRI. Why do I have to do an X-ray first?
Great.
I'm like, I don't know. I guess they're trying to minimize cost, or just sort of the knee-jerk reaction, say, start off at the lowest level, incur additional costs, do the X-ray. Maybe that'll help you answer. So the question is, what is your view of the viability of health insurance companies in 2026?
Okay, lots to unpack. So I'll try and take a couple different pieces and then maybe we can kind of reassemble. First of all, I think health plans absolutely positively have a role in the economy. There is a value added role for health plans. And to your point, it may have been clearer back in the 80s when they were there to take, risk and essentially by covering large populations, large N, to spread the risk of the cost of healthcare across the sick and the healthy, with the promise that the healthy, when they needed it, it would be there in an affordable form for them. They would have the scope and the affordability and quality that was needed. The premise is sound. The execution's been lumpy. So let me quickly touch on the market. The capital markets right now have a lot of question marks over the historical values of large insurance companies. So the bigs like United, CVS Aetna, Humana, and even Elevance, one of the blues that has been rolled up, they've been taking an enormous beating. And in the more focused government programs like Centene and Molina have lost dramatic value. So the capital markets have a big question mark over them. And last summer, when some colleagues at ZS and I were doing a piece of research around, hey, what the heck just happened? These valuations just crashed. What's going on? There was some clear sentiment in the investment circles. Like, is this an uninvestable sector? Is this, it's not a matter of like, oh my God, they're under earning now, and it's going to, it may stay that way. This may continue to be unattractive. And it was largely driven around the government programs, right? Commercial is a different animal. We'll get to that. But my view is that in some cases, like the MA crisis, the medical advantage crisis, it will sort itself out kind of in its natural way. The underwriting cycle is not pretty, but but right now, virtually every one of the MA insurance plans has pulled back benefits. They've repriced. They accept the fact that risk adjustment is going to be minimized, at least for the foreseeable future. And so, they've exited markets that they can't be successful in. They will retreat to margin, and that's something they know how to do well. What's less clear, Omar, in the bigs around this is they have also gone to integrate vertically care delivery. So, to varying degrees, the four majors I mentioned have contracted, in some cases, captive care delivery providers in their networks. And some are mixed models, fee for service and so on. Some of them are like senior care focused. But it's not clear to me that those guys, that's the right model, right? Rolling up a bunch of practices and trying to essentially manage the medical loss ratios by having care delivery. It isn't clear that those guys have been able to execute on that. It's not inherently crazy, but they don't seem to have done it all that well. So the question about, does health insurance companies belong in care delivery? Jury's out. Doesn't look that good in my mind. For insurance purposes, especially in government programs, there's, this. I mean, Medicaid, they've got 75 plus million in Medicare Advantage. Well, just Medicare Advantage alone, 35 million. ACA, though it's been chopped by one big beautiful bill, still a lot of folks in there. At one time, there's 20 million. A lot of Americans are involved in this. But I would say I'm questioning less about the insurance role in sort of especially in the government side of this business. Commercial, they've been pushed to mostly ASO. What I don't understand well, and I don't think they've done well, is their integration of care delivery by trying to do value-based contracting and so forth. It's been a very mixed bag. So I'll pause there, and I'm not sure that I answered all facets of your question.
No, I think the question really comes down to is insurance companies, and you and I worked together for many years on the front lines, and what we found was minimal managed care activity within the organization. We basically farmed out everything, right? All medical management operations, managing clinic oncology patients, nephrology patients, high-end radiology, lab was contracted.
What were
Transfer.
what were we?
So my point is, we've basically the insurance entities again, and so this is a national player, not United. United also so not only does United do all that, but then it's also pulled in bought systems, trying to manage care.
Yeah.
The idea there being that if the patient is in-house,
Yeah.
we can manage that care better.
Right. Vertical
Right.
integration is
Vertical integration, right? But this is the same United Healthcare that missed its MLR target by 340 basis points within 1 quarter. And you and I talked about this, right? They have more actuaries than small countries in terms of population. So pretty sure that I don't think the actuaries missed it. Somewhere along the way, something happened to that communication. So if you have an organization that has a top line that's bigger than the GDP of many countries, how does an organization like that miss MLR? And I think the bigger question of missing MLR is not managing care. How are you not managing care given the fact that you own hospital systems, you own one of the largest PBMs on the planet? How are you not able to manage the care for the population that you're insuring?
Well, I think there's a variety of explanations. One of them, I think, in defense of the health plan said, hey, You know, the hospitals particularly, maybe not so much professional services, but let's throw them in for good measure. So professional services and hospitals, it may or may not be about volume of encounters, but the intensity
Right.
of activity at any one encounter, according to them, was kind of off the chart, but off the charts. It was dramatically increased in 25. That makes sense to me, not so much because it's a post-pandemic kind of, still chugging through the system. It's two things, at least simplistically speaking. One, they've gotten better at it, right? They've got better coding systems to know, hey, look, this person's got this comorbidity. I need to treat for that. It's not like they're not doing things. It's not falsified. It's that they're doing more and they're costing more. And as a result, the intensity of encounter, I think, made a big difference between what some of the bigs thought. I think most of them thought medical trend would come in about 5% in 25, and it ended up being 7.5%. It's like, oh. And it moved their variances in MLRs by over 300 basis points, some more. And especially in the senior, the MA category took a big hit, especially. The commercial lines, not so much. It was mostly the MA business where I think they'd kind of gotten out over their skis on benefits. And that was the industry. I don't think any one of them, they were all kind of looking at each other like, yeah, I need to get that. I got to grow. And I need to add more to the pie. I think they got caught leaning into growth in a year where, wow, we got this intensity around these encounters, didn't forecast it, and got caught. I think that gets corrected in the underwriting cycle to come. And as I mentioned before, I think they're just going to aggressively retreat. They will cover everything that Medicare requires, but it's not like all the goodies that were out there.
Let me throw in this one little nugget. Based on my observation, a lot of the health insurance entities made their MLRs dropped significantly during COVID.
Big time.
At the same time, hospital systems were bleeding out because lack of elective procedures.
Yeah.
So no one's going to get knee replacements when you've got COVID. So if you're an oncology patient that needs regular chemo, you're going to go in.
Yeah.
If you are a nephrology patient, you got ESRD, kidney failure, you're going to go in.
Elective surgery, nah.
Elective surgery is out. Dental procedures out. PCP visits out. So MLRs dropped. So, my observation was at that time when the providers were looking for true partnership, say, hey, bail me out because we've got serious troubles. The health insurance industry I'm not sure they really were there for them.
Yeah.
And now what you're seeing is people don't have short-term memories. People don't forget. So now what you've seen is, my personal experience was, health plans hospital systems came back with really high double-digit asks.
Yeah.
And
unit costs,
your costs skyrocket. So I wonder if part of this whole process is, in terms of the sort of the ecosystem, we've lost track of how we truly have to figure out a way together. It's not a zero-sum game, although some would like to believe that. But I think that if you talk to physicians, if you talk to hospital administrators, and then, I think there's a serious lack of dialogue that resulted in everybody going to their corners. And then it comes back with a vengeance. And so health insurance companies are already operating on slim margins. Again, I'm talking about government contracts, really.
right.
They're operating on slim margins to negative margins. And if you have a situation where a large hospital system that you have to have in your network comes back with a double-digit rate ask, you're in trouble. Your business is going to go belly up.
In that marketplace. Which is what you got.
Exactly.
The market economics is what matters. This is more of a microeconomic.
Correct.
When you're doing your contracting.
Correct. So I think that, to me, that has played a very big part. I'm not, I'd love to know if you are seeing any movement back towards, hey, we got to go back to being partners rather than just trying to take what's on your plate so that I get a little bit more of the piece. Yeah. That sort of approach.
I think to some degree, so let me see if I can pick this up, Omar, so check me on this. When I think about this, I see that if you have professional, the docs, you have the hospitals, and you've got the insurance company. And to some degree, risk, the idea was maybe we can push risk from the insurance company to the docs, for the value-based care, mixed bag at best, uneven. Some are really, really good at it, but maybe 10, 20, 25% of the provider base is really good at it. I think at Kelsey-Seybold in Houston, things like that. Maybe in some of the primary care practices like ChenMed, Oak Street, which are, primary care and or focused on senior care, the clinics. But it's limited. So now one of the things I've heard very loudly and clearly is, hey, docs and hospital systems need to kind of team up in any given market to create greater bargaining power with the bigs,
Right.
especially as they come into the system. So you can see it in our marketplace in Philadelphia. A Penn, a Jeff are trying to how do I team up with the local provider communities in some way so that we can show up as a united form. So to the extent that a urologic practice or an orthopedic practice has relationships with different hospital systems, how can we show up as a partners in negotiations with major insurance companies to say, hey, brother, you want to do business in this marketplace, in this particular patient population, you need to deal with us as a unified force.
Right.
The more divided they are, the more vulnerable they are to getting kind of isolated and hurt in these contract negotiations. Because God knows, and you mentioned this a second ago, Omar, these guys, the hospital systems were getting brutalized in terms of unit cost of labor during the pandemic. The professional services guys who were used to all that volume of procedures and surgeries and so on, that got drained out. And so there's a makeup kind of spot. And they made up.
Oh, yeah.
They're making up. But I think that if I'm a provider group and one of consequence, and think of any of the orthopedic, urologic, cardiology units, you're going to want federate for bargaining power. And so to make sure that, hey, you want to deal in this marketplace, let's do something fair here for our patients. Ultimately give me enough upside and train me ultimately to get to the point where I can take downside, but don't, impose ridiculous terms on me because I'm not going to do that.
And, I think that's an interesting transition when we talk about, because I want to talk about two things here, where we're doing a lot more of the same and not addressing SDOH. I'm going to put that to the side for now. Let's get into value-based care because that seems to be the new thing that we've been talking about for 25 years. It's the new, you look at LinkedIn or you look at some SOA research, you look at any conference, everyone's talking about LinkedIn like they just discovered it yesterday. And I'm like, I think we've been talking about this for about 25 years now, but the trends are through the roof and nothing's happened. And everyone, it's fascinating to me, the obsession with value-based care. Like, it's good. I was like, how long have we been obsessed? How many years of failure do we need to have before we come to the conclusion that, is this actually working for anybody? I think about value-based care. I'm not going to talk about all the CMS models. Let's just talk about Medicaid. In Medicaid, value-based care is kind of like HEDIS measures, quality measures with an MLR target. That's sort of the gist of what Medicaid defines as value-based care. Okay, it's a bunch of HEDIS measures, 4, 5, 10,
Do the
whatever.
right thing.
Right. And exactly, doing the right thing, and hitting the MLR target. Okay, having said that, we tried capitation back in the 90s. PHOs came back in the 90s. Hospitals were thinking, hey, we're going to get insurance companies. We're going to own insurance companies. They'll funnel all the members to us. All that sort of stuff, right? And then hospitals like, now, okay, no, now we'll take on full risk. And so every time I've had this conversation, this goes to hospitals. This goes to these vendors that are fully willing to take on full risk or some sort of value and risk. And the question always is, you are barely hanging on based on your current model of delivering care. Now you want to act like an insurance entity as well? Do you really want that sort of headache to have sort of insurance infrastructure? Because that's what value-based care requires, or any kind of risk contract requires that. You need to know what your payments are going to look like. You may have a capitation, but if you've got a risk corridor involved, well, guess what? There's a downside of these things, and you may have to accrue for that. And you won't know anything about that till about 9 months into the year, because the insurance company doesn't have completion. So, I question, again, I'm putting the specific models aside, but I'm trying to understand, what is the purpose of value-based care? Are insurance entities just trying to dump risk on the hospital systems?
I think
Do
they
the
think
hospital
that.
systems truly believe that they can do a better job on risk, given the fact that they're they're physicians and surgeons and not business people.
Yeah.
I want to try and really understand, what I understand the premise of value-based care, better quality, and will give you money.
And at a just more efficient care
Right,
for an equal or better outcome.
right.
But since we don't measure outcomes, what are we anchoring it?
What are we anchoring it? So that's the other thing. I'm just trying to unpack, and it's a complex topic. Certainly not for one podcast. It probably require multiple podcasts to address this and multiple people. But where have we lost the way on value based care? Because if this was supposed to have any teeth to it, it would have delivered value 23 years ago, 20 years ago, 18 years ago. 25 years later, trends are through the roof. Everyone's still talking about it as if they just discovered it. So I'd love to just get your thoughts on that.
Yeah, just some macro comments because this is something we've just delved into pretty in depth here recently, and mostly in connection because most of the large publicly held companies, especially those in the Medicare, I don't hear about it as much in Medicaid, and you know better than I do. But it's just like you say, it's mostly sort of like hit your markers on quality and so on and so forth, which is great. But I still feel like, does that have anything to do with outcomes? Or is it these patients are churning so much, I don't even track outcomes. I warehouse them for a few months or whatever the life of their term is. So the fact that we don't have it anchored to outcomes is always going to be problematic for VBC, because then it's a matter of how many ER admits did you avoid, how many hospital admits did you avoid, and it's like, well, hold it, what's that got to do with wellness or health? And so I think because it's a bit distorted in the outcomes, it's like keep them away from expensive sites of care, right? And call Mrs. Jones 3 times a week and manage her Lasix so she doesn't have to go to the ER. Like, okay, that feels like, a good thing, but it feels also unsatisfying in
Yeah.
terms of
It's a it's
wellness.
it's they're just checking off boxes.
Yeah. So VBC to me, in principle, was supposed to solve high quality care at a at a better cost, right? The cost curve should be at least moving cost per life should be moving in a positive direction. Not happening. And in some cases, the uptake by the provider community, excuse me, and I'll include hospitals and providers in this, it's been meh. There are some really good operators out there. Kelsey Siebold is the one I use as my go-to example in the Houston area. It's a physician-owned group, very large group, dominant in that region, and has been, by all accounts, can handle global capitation. They're taking on full downside risk in certain populations. They've got a full multi-specialty. They've got close relationships with the hospitals in the region, probably contracted. So these guys know what they're doing. But I think that that's not all over the country. There may only be a half a dozen, maybe a little more states in the country that have enough experience. California, Texas, Florida, Oregon, maybe, there's some folks that have Nevada that have some experience with this, but it's not pervasive. You go to the Northeast or to the Midwest, it's kind of very spotty. So it's not something that the marketplace is ready for. And in fact, I think all of the majors have suffered, Omar, in terms of trying to push risk to these provider-based risk-bearing entities. And right now, it's just not. I think there's 3 things. Are you in the right place? Is there enough density of patients that's in your panel? Is there enough density of providers to be able to kind of complete the circuit for care? And then do you have the professionalism? Do you have the proficiency of the docs? And then are they contracted in a way that progresses them from what was once a fee-for-service model to a viable risk-bearing entity? Like, not everybody's ready to do that. And how quickly you move them, it could be anywhere from 3 to 5 years that you mature a patient through a VBC life cycle. So you're underwater in the beginning. And to your point about the administrative proficiency to say, hey, by the way, did you reserve properly for for claims or what? That competency generally sits in an insurance company. So this goes back to one of your first questions about what can insurance companies do. I think that they could be a machine, a mechanism for progressing the provider community to be more efficient at risk bearing. but they kind of flubbed it the first time through, right?
Exactly. So this circles back to our first question of what is the value of an insurance company today? And in my mind, if you are not collaborating, if you are simply dumping risk in the hope to get your 2% margin, it's going to come back and bite you. You're not going to get that. You're not going to get the return. It is in your best interest, I think, as a health insurance operator, to really bring the hospital system into the fold.
Yeah.
And help them through the risk-taking capacity journey, which you said 3 to 5. And I think that is the role that we need to, from a health insurance perspective, we need to adopt. Meaning, if we want care management in place, we have to bring the hospitals, our brothers and sisters in the hospital system, together along with us to help them understand what risk-taking means, so that they make sure that they are fully engaged in the process. And I mean, you've had local hospital systems here go bankrupt.
Yeah. And maybe, this idea of progressing the supply chain, the vast majority of providers and hospitals who are consolidating, right? Hospitals are consolidating, some are disappearing. Right here in this area, we've lost a few in the old Crozier system. And so the consolidation of the supply, the unification and maybe even ultimately professionalism of some of these provider systems to handle risk is a work in progress. Can the insurance companies with the large patient or member base help blunt some of the adverse effects of like, hey, I got too small a panel, too small a population pool, and a few big claims can kind of blow up my margin. Help me spread that risk, number one. So set corridors for me and help me progress through this. Ultimately, maybe like the commercial world, I've got hybrids. I got stopgaps. I'll cover you outside the corridors, guys. But because the closer it gets to the provider, theoretically, and I'm still buying that, the more precise, the more effective, the more you're just proximal to, you got the provider proximal to the patient bearing that risk responsibility. But today, they're physicians. They're trained to be healers, not to be arbitragers, right? And so there still is an administrative and pricing aspect to this. There's still the notion that I don't know how long it's going to take, but it's not 3 to 5 years to get the supply base to this point. It could be a generation or two. But if the hope of VBC is to be fulfilled, I think the insurance companies could have a role. They may be taking themselves out of their current jobs, but they could have a role in migrating risk to
Correct.
proximal to
Correct.
the provider.
Correct.
And I think if you read the public pronouncements of the majors, they believe it too. And they don't talk about the end of our business. The business will transform. Our value proposition will transform.
When I think about it operationally, as an actuary and from a data analytics perspective, health insurance companies could actually develop actuarial analytics dedicated to their larger hospital systems, supporting them in understanding where the large claims are coming in, so that the hospital system doesn't have to reinvest in hiring their own actuarial teams and to do so if the claims data is sitting with the insurance entity, and that's another debate we can have of where that claims data needs to sit, but you can dedicate actuarial analytics to support all the large hospital systems in your network, to educate them and guide them on in the insurance entity when you have a monthly close process that goes through the reserving process, that looks at large claims, that looks at all the erratic trend patterns. It's the same support that you can provide the hospital system because they're now taking risk. I mean, I don't think a lot of people know this, but the actuaries know this because they got to sign off on this stuff. Provider solvency. They got to sign off on provider solvency. If you're doing at risk full capitation or any kind of capitation risk,
Just like an insurance company.
right, you got to sign off on the fact that your provider has to be solvent, because guess what happens if the provider's not solvent? What's going to happen to the member? So it's something that I think that we as an industry, at least from the health plan side, needs to do a better job in circling back and making sure that we are not just financially contracting with these hospitals, but really at a more granular level are integrated better with the hospital systems as one combined piece that's taking care of the members. And I think that's where we sort of lost track of who we are,
Yeah, and I
of
think
who health insurance plans. And having worked in health insurance plans, that's why I keep saying who we are.
but this is a political scientist in me. Collective action problems are one of the hardest things to crack, right? Because now I have to coordinate and collaborate to do it, and so who does it first?
Right.
And so imagine, if there's a lot of free riders, right? So even in the case of pharmaceutical with the PBMs, who goes transparent first, right? Cigna said they would, and they took a beating in the marketplace, right? That's a great reward. So to some extent, how do you regulate sort of the right behavior outside of a public good that gets managed by a government, which makes me shiver because I don't know that the feds necessarily have any better grip on this or some regulator would. So there's a tension in our system between public and private good. You'll hear it in even the debates about Medicaid and ACA and so forth. How much public money should we put into health care for those that are vulnerable and can't afford it? Well, one big beautiful bill answered at least one edition of that. And whether we agree with it or not, there is an ongoing debate in the country about how much of this is it's private good. Leave this, to be handled through the insurance companies and the providers and let them duke it out in sort of a purely competitive model, right? Adam Smith, the invisible hand. I think that to your point about collaboration and coordinating, it has to. I mean, what are we competing on? Arbitraging on labor costs by geography? Like, why does a procedure identical in nature cost so much differently around the country? Well, labor costs might be one of them. San Francisco is more expensive than Omaha. I get that, but there's inflation adjustments and so forth. Versus I can take advantage maybe of my monopoly power in that market, right? Look, there are some structural defects in our system. I firmly believe that there's a role for the insurance companies going forward, but I believe it needs to include facilitation of the provider systems combined, ideally IDNs and so forth, in a way that they can bear risk. And let's create the administrative mechanisms to help them do that smartly. Let's create contracts that create risk corridors that are doable for those kinds of businesses, right? And that catastrophic risk sits outside of it. That's what big, honking insurance companies should be really good at.
Correct.
Not paying for, my dental allowance or something like that. It's ridiculous.
So, speaking of this, in terms of the relevance of insurance entities in 2026, you and I have discussed this issue with some of the larger blues plans that have, and I've maintained this, every plan that I'm aware of has gobs of analytics, right? I mean, one of the blues that I'm aware of had like an inch thick pile of reporting practically every month.
Yeah.
So my hypothesis is they have plucked all the low hanging fruit and then some, and yet they're losing billions. Okay, so if you've been doing, it's that definition of madness, right? Doing the same thing over and over. You've done the analytics 9 ways till Sunday. You do it every month. You got teams of data scientists, actuaries, clinicians, provider contractors pouring over the analytics and saying, "Oh yeah, we have to this avoidable admission or rerouting this ER or managing this oncology member, blah 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 blah, all day long." Yet they're losing billions. So the question then is, why is an SDOH being recognized as a new lever, even though it's not a new lever, to pull? So, and for the audience that may not know what I'm talking about literally is the fundamentals of a healthy life, which is food, shelter, transportation, education, and language barriers. So I discovered the other month that once in Spanish means once means 11. And so if you say once a day, they might be a patient that says, "Oh, I got to have 11 of these pills." So just something as simple as that can be catastrophic for a member whose English is not a first language. So, in terms of being relevant in 2026, we know that practically half the sort of your diseases are a manifestation of your choices that you've had or not had throughout your life when it comes to food and education and what have you. Why are we, when we talk about preventive measures, we're not talking about just mammograms and going to the, it's too late. That kind of stuff, you're pre-diabetic. Okay, now you're diabetic. By the time you're pre-diabetic, you're pretty much on your way to being diabetic. And so, unless somehow you figure out, how to avoid it, which I have rarely seen that happen. So, if we're talking about being relevant, game changing, and I hate using that word game changing because it's not a game changer, it's common sense.
Yeah, it is
Why don't you
common
spend
sense.
a few bucks on food, clean food, instead of spending millions on the back end? Because by the time you spend millions on the disease that you're trying to now take care of or address, you could have addressed that, many years ago
Yeah,
with a cheaper alternative of food.
and this certainly is an argument that travels across a couple of different sort of social dilemmas, right? Think about antisocial behavior. If somebody had had the opportunities and been, in a less violent neighborhood, had had a better home life, maybe they wouldn't have ended up, in the prison system. So there's a bunch of social dilemmas that sort of fit this model. But the social determinants of health, and I don't know, real quickly, you can check me on this. I mean, SDOH, as you mentioned, is what, 80 75 80% of the explanation of health out. But for the most part, there's tokenism. In Medicaid, which is where this shows up a lot, sometimes in certain ACA populations, but it's token. Every RFP we did always said, "Hey, what are we doing about SDOH?" And it was always margin killers, right? It was always add-ons or sweeteners to try and position our proposal better. It was never in the rate structure except for some, and you know the exact words for this, some sort of 5%.
No capitation built in.
Right.
Nothing.
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 So basically it was like on you,
On you, right?
right? And it would be, what's the word? Ceremonial, right? We do these like programs that were tiny, affected the population in a minority way. Or if a state had petitioned, like North Carolina, to get an 1115 waiver, you might get some money in there to do a real SDOH kind of program, which they did with one of the important ecosystem members, Unite Us, that helped kind of filter, okay, where can I go to get these services? I know I just did a disservice to Unite Us because they're more than, a routing service. But I think one of the other fundamental problems, especially in Medicaid, is that if you do these programs, will the benefits that accrue to the member accrue to the insurance company? Because that member churns out. And you've made some very eloquent arguments about sort of the economic sense of SDOH. But there's a wrong pocket thing, right? Like I could get Omar, dude, I got you out of the food desert. I got your transportation. You're on the road to recovery. The payoff comes to whoever they're with when maybe they come back into Medicaid and they're healthier. It doesn't accrue to the one who incurred the cost. So this wrong pocket problem is a dilemma. And I think that it's solvable, but it's a dilemma. And I think it's in part harmed the SDOH. The other is that whenever we talk about SDOH, it's always should. It's a should kind of thing, not a you got to do this.
You got to do this.
Right? This is mandatory. And so I think in my mind, unless and until it becomes mandatory and is capped in part of the rates, I'm kind of cynical about it,
Yeah. I
unfortunately.
think, you raise a good point. The problem, honestly, is you have 1-year terms in health insurance.
And this is
that's
a
the fundamental problem.
That's a structural problem.
That's a structural problem. If you can if you can move away from 1-year terms, because look, anytime you do any kind of disease management intervention for a new population or even a population that's used to any kind of intervention, it's going to take a few years.
Yeah.
It's going to take 2 to 3 years to
And
realize
you'll
the
do it in
saving.
a DSNP.
Yeah, correct.
Because if I have continuity of that
Yeah,
patient,
yeah.
in that member because they're dual eligible, they're of an age where they're going to want, and maybe they're even chronically ill, so they're not going to want to disrupt their care providers by switching all the time. So there's a stickiness to a DSNP member. So I think it could work there, and I think there is, but they're by this time they're chronically ill and have
Right.
multiple comorbidities, right?
Correct.
It's a that is where, and I failed to mention this before, you touched on it. Care management. I believe, and because the insurance companies outsource so much in this regard, not all, but many outsource so much of this, this could be an absolute vital part of their value proposition. Bring scale at the market level to care management and make that work for the populations. And it doesn't have to be an MA, Medicare Advantage, or it probably will start there. It'll probably start in a D-SNP population, maybe C-SNP. But I mean, where you have some promise of stability and you can really move the needle. But these patients, when you get them, I mean, you're underwater for
Yeah.
probably 18 months to 24 months.
Correct.
So you got to be able to stay with them and you got to be good at it.
Yeah, and so, any kind of analysis I've done on SDOH suggests that you're talking about 12 to 15 months to sort of implement the program if everyone's a go, rather than competing priorities. So if everyone's aligned, 12 to 15 to 18 months to set it up, and then savings start to show up 24 to 36 months. So at a minimum, you need the member around for a good 2 to 3 years for the insurance entity to realize those savings. And I think that, to me, the irony of all this is the states with their, oh, we're losing money. Oh, we're making money. Oh, we're losing money. If you were able to provide SDOH capitation at the rate cell level, the member would stabilize, the claims would stabilize, the insurance entity would stabilize, the MLRs would stabilize, and guess what? The state budgets would stabilize. And so if you were able to fund something like this, the entire infrastructure would stabilize over the course of 2 to 3 years. And it's baffling to me. I had a conversation with some CMS administrators a couple of weeks ago. They fully recognize that. But where are they
Well, you're
in
right.
the actuarial soundness of all this?
Yeah, the budget cycles certainly seem to distort the lens. And this goes to one of the things that in our paper with ZS, we talked about sort of the strategic lens to view this through. And I use this relatively unkind term. I said, look, there's a veritable trash can full of ideas that got tossed either because of that's going to take too long. I need in-year savings in order for this thing to work, or I can't do that myself. It's going to take, some I have to expend some effort to collaborate with others to do it. There's sort of these factors that sort of say, yeah, no, I need in-year, I need to do it myself. I need to show performance. Those are not crazy thoughts, but unfortunately, that trash can's full of ideas that, like VBC or even SDOH. I mean, I think about some of the times we wanted to go look at some of the more credible providers saying, hey, we'll take the 5%, the most acute members in your population today, and we'll take them and split the risk with you on trying to bring them through a more aggressive care management program, City Block and others, which I think is a very interesting value proposition. It never worked because we weren't patient enough
Right.
to say, no, that's like 3 years before we see the numbers.
Of course.
Really?
Yeah.
Is that going to work? So it asked the decision maker to say, do you believe enough that you'll expose a 3-year time frame to see whether these results are coming or not? And it's not a matter of blame or like you're not smart enough. It's just that the impatience, though, it seems almost built in, Omar, and it distorts the decision maker's lenses.
100%. I mean, I don't understand why. I understand, okay, the United of the world have to get in front of analysts and give every quarter, whatever. All right, fine. But why do private insurers, they don't have to fall for
They don't.
the annual,
They don't.
quarterly.
They theoretically have patient capital.
Correct.
Right.
So they have the ability to deliver over the course of 2 to 3 years if they actually firmly believe in what it is that we're just discussing. If you're able to change your time horizon from I'll give you an example how absurd it's starting to become. I was at this conference where this vendor, and you talk to vendors, they're still hawking stuff from 2002 where we can reduce trends by 5%. And I'm like, all right, man, I believe you, sure. Moving on to the next vendor. And so I come across this vendor who's got diabetic socks. Fantastic. I'm sure there's a problem. What's your sample? Actuary speak. What's your N? What's your sample size? I'm like, off the top of your head, I don't know what the sample size is. I've never done analytics on diabetic socks needs. Anyway, having said that, I just threw out, because I was being a smart ass. I said, hey, would you be willing to take on risk? Yeah, we'd love to take on risk. I'm like, are you cracked? I'm just kidding. You should not be taking on risk. Do you have any concept of what that actually means? This is how absurd it's becoming. You've got organizations that are so desperate for revenue that they will jump to anything just to satisfy the masters, whether it's a PE firm or whatever, for the return. And the reality is, and then on top of that, the insurance companies are saying, hey, we don't have time for 2 years and 3 years. We want to do this in 1 year because we're losing our shirts. We're bleeding out. And so when you have no money, and, I mean, I always make this joke about, I don't know how your checking account works. My kid's checking account is linked to mine. So when their checking account goes below zero, Wells Fargo texts me immediately. Hey, you better top it off. We're going to shut it down. So I don't know how it works for these insurance companies, but if their checking account's been negative for the last 2, 3 years, which it has been, unless mommy and daddy are topping it off, at some point, those capital adequacy reserves are going to be hit hard.
Absolutely
And,
right.
and then shutdowns come around.
Yeah.
So,
Or consolidations, right?
consolidations. And so, you've got these vendors that are just desperate to take on risk. You've got these hospitals that are doing this because we're stuck in this 1-year constraint.
Yeah, it is a structural defect. And so to the extent that we could relax the churn, and I think it's going to be, in fact, intensified in Medicaid, right? Because of all the validation requirements now, work requirements, and so on and so forth. So I think it's just going to get worse in Medicaid. And therefore, those margins were never great in, even in the best of times in the cycle. So I wouldn't be looking in that direction. But I think in the Medicare Advantage field, most definitely, I think that's a market that'll never perhaps be what it was in 2019. But it can be, if now that there's been sort of a system-wide pullback in benefits, and in fact, some of the bigs have just sort of, I know Humana went big this year in terms of their MA population. United said, no, I'm going to shave a little bit. The others not so much. I think that business is probably sound long term. The ACA business has probably been a big reason why Centene has just went off a cliff in the last few days.
Yeah.
It's just been brutalized.
Right.
And that was once it started out rough, got stable, and then just
went off a cliff.
Right. And I think at this point, I would be pretty gun shy if I was an insurance company around that. So what other value propositions can the health plans come to in the bigs? I think we have some ideas for that. We talked about it in terms of enabling the supply chain to get to the point where at least they can handle a risk corridor and taking the catastrophic risk out of the equation. And then also, like an Optum Insights, they can provide tooling, right? There's all kinds of tooling out there for making these guys better. But in care management, this is something I feel like the regionals could rock the world in, right? I do believe there still is consolidation that's needed in the regionals. I don't think a BCBS Massachusetts or Michigan can and should stay one state, and I know these consolidations are not for profits are going to be lumpy, but I think these are difficult times, brother. I'm not a believer that this is just an underwriting cycle away. I think there's challenges fundamentally, and consolidations can solve, at least buy some time, give me a little less pressure on my admin cost ratio, that maybe I can get smarter, better, and get a little bit ahead of this.
Let me ask you this. So at this conference, there were a bunch of PE investors, and they're all dancing around the periphery. We're going to invest in artificial intelligence and blah, 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 the usual stuff, right? And I'm like, well, why don't you just buy a damn insurance company and turn it around? Why are you dancing around the edges and we're going to do IT this and AI that and some care management protocol and blah, 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 and some health tech, blah, blah. Why don't you just jump into the fray? You've got the money, buy a regional health plan, get rid of all the fat and turn it around and get your 5X and whatever number it. None of the PEs had an answer for it.
Interesting.
And I was shocked by that. I was like, I'm surprised at the lack of response or lack of interest. Some of them are like, we do small investments, blah, blah, blah. And I'm like, well, where are the PEs? There used to be this time where health insurance entities were, and this goes back to our first question, if we believe that AI can eliminate 40% of jobs and there are fat-laden jobs in IT and med management, what have you, even finance, there's a lot of fat there and bureaucracy that can be removed. Why are PEs not looking at these as great investment opportunities to come in and think out of the box? Because here's what's happening in the insurance world. You've got churn of the C-suite. So all you're doing is the CEO, the CFO, the chief actuary, blah, 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 from XYZ Blues goes to another Blues. And then that guy goes to another Blues.
They live in the same system.
They live in the same. So it's not like you're getting somebody from Amazon or Tesla or somebody else, like, hey, I'm going to come in and turn this around. You're getting the same, sort of stale ideas just thrown around this in a merry-go-round
Oh, yeah.
or revolving door, I guess. So, what the potential turnaround strategy can be for a PE firm that's invested in this area. So I'm going back to sort of, the work that you were doing originally. What was their ultimately thought that where they think that they can improve or do something with these health plans?
Well, I think we were pretty clear that the MA book, the classic MA insurance book, you can get that business healthy in a reasonable period of time. Maybe it isn't the roaring machine it was in 2019, but you can get it to a better place. And there's things you can do. You can, and the big challenge was in the vertical integration of care delivery. That their first attempt at this had either been too small or they were too aggressive, right? They bought up practices or contracted with practices that weren't really fit for purpose. And they wanted to move them too soon into more progressive forms of risk bearing than they were really ready for. And so some of that is like, oh, I have to undo some of that, or I need to, like a CVS Aetna has kind of been a little tippy toe around it, right? So it was a very sort of tentative in some cases, over aggressive in another. I think the firm belief is some of like for example, in a United, they've got some, lines of business. Their PBM, notwithstanding what's coming in terms of transparency, the PBM is still a lucrative asset. You can argue whether it's a melting glacier or not. The Optum Insight is very attractive in terms of some of the technologies they have and what they can do. I think it's probably a machine for producing some nice profits as they equip the industry with some of the intelligence that's needed to manage care more affordably. I'm just not sure that the scale that normally companies like Humana, CVS, Aetna, and so forth would bring to some of these businesses is suitable in care delivery. I think the excellence tends to kind of be bounded by the marketplace. You can knock it out of the park in the Philadelphia, South Jersey, some sort of geographic bubble, but it doesn't necessarily travel because there's, the way the provider institutions are organized. It's not like Penn isn't a national institution,
Right.
right? It's a Philadelphia
Right.
institution.
Right.
So I think the boundaries around scaling and optimization are more at the metropolitan market space, right? So I don't think the scaling principles work as well on care delivery. Having said that, the regionals could kill it here, right? Could kill it because of their brand. And I think their brands are so locally dominant, whether it's a Highmark, an Independence, et cetera. I think these brands are powerful locally, and they could unify care management in an infinitely better way than, some of the bigs. But the bigs will take it to them on the other lines of business.
Right.
So, but there's some the regionals have been struggled in 25. There's an element of underwriting cycle to that, but I think they could use some scale. Quite
Yeah.
honestly,
Yeah, I agree.
even just to drive down ACR, let alone. And then your point about talent is a big deal as well. Like, you need some thoughts about how to even do this, right?
Well, my friend, that is going to be for another day. I thank you so much for your time, for your brilliance. I really enjoyed it. I learned a lot. I always learn a lot whenever I'm with you.
I learn a ton when
I
I'm with
love
you.
to have you back,
Absolutely.
and look forward to doing this
Strategy and actuary
again. Strategy, actuaries. We got to work together, man.
forever. All right, buddy.
Forever.
Thank you.
Thank you, man. Appreciate
man.
it.
Oops,
All good. Thank you.